Great. So I think people are filtering in from the Zoom waiting room here. This is Catherine Smallin, the patient navigator for the HEALEY ALS platform trial, tuning in from Boston, Massachusetts with the HEALEY and AMG Center for ALS. This week's webinar is going to be hosted by the brilliant one and only Dr. Suma Babu here at the HEALEY Center. And Dr. Babu will introduce everyone here to our special guest speakers. We've got two wonderful guest speakers this week. So I will hand it over to you, Dr. Babu.
Thank you, Catherine, and thank you for your kind words. And thank you all for joining us for this webinar. This is a monthly series on EAP that I always look forward to, and it's an exciting topic, and it's an evolving topic, and I learn a lot from the audience as much as we'd like to share the knowledge we have learned from all our experiences. And today we have an all-star panel for today's webinar. And let me introduce Amanda Stevens and Dr. Namita Goyal as our panelists for today's webinar. And without much ado, we can go to the next slide. And maybe Amanda, if you could go to the next slide. Yeah,
Yes.
Amanda, if you could maybe share a little bit more about your work and about yourself, and we're looking forward to your talk.
Yes, absolutely. Thank you so much for having us. Hi, everyone. My name is Amanda Stevens. My husband, Eric, and I started the axeALS Foundation in 2021 after he was diagnosed with ALS at just 29 years old. He was diagnosed in 2019. So just to start off, we're working really, really hard to raise awareness and funding for ALS treatments and clinical trials to help patients and their families, and then encourage research to hopefully one day find a cure for this awful, awful disease. You can go ahead and go to the next slide. So my husband is a former NFL football player and a former firefighter. So that's kind of where the axeALS came from. His diagnosis came just 1 month after our wedding. And so we decided to start this foundation because I remember one of the first things that Eric said after he was diagnosed was, I know that I have such a big support system. What about those patients suffering that don't have anyone? And so that kind of sparked our fire to start this foundation. And like I explained in our mission, we have 3 main goals. We want to raise awareness and funding for EAPs, like this one we're going to talk about in clinical trials, help other families that are struggling with this disease, and then contribute to research as well. And so since Eric has had ALS for almost 5 years now, at the end of August, it'll be 5 years, it means he no longer qualifies for, I think, all clinical trials. And we know that a huge majority of ALS patients no longer can participate in these clinical trials as well, which is why we wanted to work really hard to raise money and start an EAP program at UC Irvine with Dr. Goyal. And so we'll get a little bit more into that later, but we've granted over $100,000 to other families fighting this disease. And then we did the partnership with the HEALEY Center and Mass General and UC Irvine with the EAP with a commitment of $486,000 over 3 years. You can go to the next slide, please. So a lot of our donations and our fundraising come from our golf tournaments. We hold at least 2 golf tournaments a year down here in Southern California where we live. And at these tournaments, we are looking to raise a lot of money so we can open more expanded access programs and just help more families battling this disease. A couple months before the golf tournament, we open up a grant application and ALS patients can apply to receive financial support. So you'll see in this bottom picture, we gave a check to a young man who was diagnosed, I think, a year ago. And in the top left one that was at our Newport Beach tournament last year. And so we really, want to help families that are going through the same thing that we are. Our next tournament is November 4th in Long Beach, California. And so we'll open that grant application in September. So we do it, 2 months before so we can review the applications and choose a family to help. You can go to the next slide, please. This is our family. Despite ALS, we've chosen to really just, live each day. It's really opened our eyes to how precious life is and how we're not going to let ALS stop us. But at the same time, we know how destructive it can be. My husband was the strongest man I've ever met, and now he's 100% reliant on me. And these 2 little kids. My daughter helps out a lot too, thank God. But we really want you to know that, we're battling this too. We feel the urgency too, and we're doing everything we possibly can. I need my husband here. My kids need their dad. And so, yeah, we hope that you help us change this disease from terminal to treatable. We're working so hard, and with thanks to Mass General, Dr. Goyal, you're really giving patients, a chance to fight, which is something that we've always said from the beginning, that, just give us a chance to try something, try a treatment. And yeah, so the last slide, you can go to that one. That's a QR code to our website. You can find out more information about our foundation at axeals.org. And yeah, thank you again for having us.
Thank you, Amanda. And thank you for sharing your story, and what a beautiful family. Thank you for sharing those pictures.
Thank you.
Dr. Goyal.
Hi, everyone. First of all, thank you, Dr. Babu and the HEALEY team for inviting us to talk today. Amanda, I know Amanda, and every time Amanda speaks, I just feel so emotional and, so grateful and honored to be in her care and the family's care. But I feel this way about all my patients. So Amanda, you made me emotional. I need a second, but you spoke very well and you hit the nail on the button that we just really, really want to fight for our patients. We really want to find that treatment to stop this, to prevent this, and, get that cure out there. For the people on the call who don't know me, my name's Namita Goyal. I'm a neurologist and neuromuscular specialist, and have really devoted a lot of my career to trying to help fight ALS. I actually started my career at Mass General, and I did my training there, and I was on faculty there for 7 years. And I have now been at UC Irvine for 13 years. And I noticed, before I moved out to California, that many of the trials and the work were centered around Boston. And when I would look at the map of clinical trials and what was happening on the West Coast, I actually talked to Dr. Merit Sikovich at MGH, and I said, I want to help bring clinical trials to California and really grow the clinical trial site in California for our West Coast patients. And I'm proud to continue to collaborate with the MGH team and the HEALEY Center to do just that. So now I've been at UC Irvine for 13 years, and I'm proud to show you the team that we have. We have a number of clinicians that see ALS patients. We have a great nurse. As all of you know, this takes the team to really fight this disease and provide the support that all patients need. And so we have that multidisciplinary team. And we also have a robust research team. It really takes a village to even lead a clinical trial. And I'm proud of the team that we've built to bring the trials to the West Coast. If you can go to the next slide. This is just a list of some of the trials that we've been involved with. So if you look at the interventional drug trials, these are the trials that we've been involved with over the past year. The observational trials mean that these are trials where we are trying to collect data to understand ALS, and then we have a few more upcoming. And what we're here to talk about today are the expanded access programs. In the last year, we've been involved with 2 expanded access programs, HEALEY and the CNM AU8. And upcoming, and hopefully very, very soon, we'll be starting the predopidine EAP. And hopefully within a few months, we'll be starting the RAPA EAP. And I'm happy to talk to you in more details about that. We can go to the next slide. And just to summarize for you, for those of you that aren't familiar with expanded access programs, really the purpose of expanded access programs are to make available drugs that have not yet been FDA approved, that are still under investigation, but for patients that do not qualify for a clinical trial based on some of the very strict eligibility criteria that it takes to enroll in a clinical trial. And we, on the investigator side, understand that. We understand that many ALS patients want to try these drugs. And so this is sort of how the expanded access programs did get created in ALS. It's basically for the patients that don't meet those eligibility criteria. And I just put on here some of the main things that many of these expanded access programs look for are some of the criteria that, for example, don't fulfill the HEALEY platform clinical trial, which is having ALS symptoms of more than 3 years or a breathing capacity of less than 50% can disqualify you for the HEALEY platform trial. And that's why we said, hey, but let's at least see if we could get you on an expanded access drug. And like Amanda mentioned, at UC Irvine, this has been made possible because of the grant and the collaboration we've done with axeALS and the HEALEY Center in order to bring some of these newer drugs that are still under investigation to our patients to get them a chance to try it and see how they feel. And I'm happy to go into more details on these programs, but I thought I'd pause there so we could ask the questions that you guys want to hear about.
I think we can keep going, Namita, with your talk, and we can consolidate the questions as well. If anybody would like, I don't know if the audience is able to come off of mute and ask questions, or is it mostly it's only the typing? Okay. And so we can keep going, and then we can address the questions.
Oh, okay. Well, yeah, I mean, there are 2 expanded access programs that we have done. Like I mentioned, Trehalose and Clean were both drugs that were tested in the HEALEY platform study. And we have had them in an expanded access program. And then you guys may be familiar with predopidine, but predopidine is a drug that is being tested in the expanded access, in the HEALEY platform study. And in the platform study, you may have seen some of the results were released, suggesting that overall, the drug did not slow progression in the entire patient population based on the ALS functional rating scale. However, there was a subset of patients, especially those patients that were early on in the disease, that they did see slowing of progression, which is why we thought it should be reasonable to move it to an expanded access program, where if other patients that don't qualify for the HEALEY platform trial wanted to try the drug, we could have them try it in the form of an expanded access.
Thank you. There's one question about, do any ALS clinics believe that the EAP regimens would be useful as an adjunctive therapy, as there are only 2 FDA-approved medications for sporadic ALS?
Yeah,
Dr.
that's a
Goyal.
great question. And I think, you know, what we believe in ALS in general is that the 2 FDA-approved medications should be our standard of care. And so most clinical trials are all designed to include riluzole and Radicava or Edaravone as our, you know, standard of care medications. And if we have a new drug, it would be adjunctive therapy. So both in the clinical trials as well as in an expanded access program, we always let patients be on the 2 FDA-approved medications like riluzole and Radicava, and this would be an adjunctive therapy. There is some thought and, you know, wondering if, you know, almost like cancer, do we need to target and use multiple drugs to try to slow down ALS progression? And some of the thoughts are, yes, you know, why not try attacking possibly the different pathways that may be involved in causing ALS?
Absolutely right. And then there are a few questions coming up. There's one question about why don't the EAP compounds directly go into a phase 3 trial? And are they considered as substandard adjuncts and hence not FDA approvable?
Yeah, that's a great question. And I think it's helpful to understand the purpose of the EAP. So really the purpose of the EAP is to give patients who don't qualify for a clinical trial access to the same drugs that patients that do qualify for a clinical trial have access to, while the drug is still under investigation. So the way I look at it is it's basically the same drug, and the purpose is for patients that do qualify for the trial, let's study it in a formal phase 2 or phase 3 study to try to see if the drug is effective enough in slowing down progression where we can get FDA approval. But we as the ALS clinician scientists also understand that there is an urgency. ALS patients want drugs today, want that cure today. And so while a drug is in investigation, let's at least get those patients that are not on a drug trial on something to see if that would help. So it's almost the way I look at it is they're parallel paths, and both paths are to FDA approval. It's just, it's not that this drug is substandard. It's more like it is actually of standard, and we do want to see if it'll get to FDA approval. But in that path to getting there, we want to give all patients access to any drug that's out there.
You're absolutely right, Dr. Goyal. And I would also add to that to say that sometimes EAPs, where they start, where they come into a field, may actually differ depending on the drug development. Sometimes EAPs may actually be launched as early access after the phase 3 has been completed. Like, for example, the tofersen, or if tofersen was approved based off of an accelerated approval pathway. We're still waiting on the ATLAS study in the pre-symptomatic cohort. But in that case, the Valor study of phase 3 or their pivotal study was completed, and they were awaiting the final approval, and that was a pathway to allow early access for participants or patients who couldn't otherwise get into the trial. So sometimes EAPs, in most cases, EAPs are running in parallel to phase 2, phase 3, as Dr. Goyal mentioned. And the important aspect for expanded access is that you have to have safety information about the drug that's being given through an expanded access protocol. That's an important requirement in many ways, because the expanded access pathway that is meant to add more flexibility in terms of study visits, in terms of making it as patient-friendly as possible. And we don't want to lose the rigor or oversight, and especially safety oversight for patients. And sometimes it's also considered as an extension of clinical care. So again, there are some little bit of trade-offs there. If you're bringing in some flexibility, we want to make sure that the safety is not jeopardized in any way, especially these are experimental drugs, and we don't know that the long-term safety of some of these medications. So if we know the safety of the drug, and entering into an EAP. So that's part of the reason why many of the drugs enter while they're in phase 2, while some safety is already known from phase 1, and there is the efficacy testing that is that's running in parallel as well.
Yeah,
Yeah,
I
go ahead.
agree with that, and I would say, I would add that it's almost like a trial in itself because
Yeah.
we are collecting that safety data, and that's just as important. And I thought that was a very important point about the visits become less rigorous for patients
Yeah.
because we know about the burden of a clinical trial. And so this allows for a little bit more flexibility, some phone call visits, less frequent visits.
All right, and there are a few questions from the audience. There's one question about NU9 or Akava Therapeutics. I can take that question. So do we have any updates or information about NU9? So I don't have the latest updates about that, and Dr. Goyal, feel free to chime in as well. The last I heard is from late last year when the team was planning to launch a phase 1 healthy controls first in human study. It's an exciting science backing the compound and the mechanism of action, and Northwestern University is leading this effort with the company. And so we're looking forward to more information about that.
I heard similar
Yeah.
scenario. Thank you.
And then there's another question here. How many ALS individuals are sought to enroll in each of your 4 EAPs? And how many were enrolled? Probably referring to one that's already ongoing, and they're the ones that are being launched. So Dr. Goyal, would you like to take that question?
Yeah, I mean, if it were up to me, I would love to enroll every single patient that does not qualify for a clinical trial and give them the access. And a lot of our plans for enrollment are actually not investigator-based. They're either based on the funding that's given to a certain center or the amount of slots that are given to the center. You know, sometimes EAPs are designed so that different centers all have equal opportunity in getting a certain number of slots. In the TreeHello study, I know we had 3 patients that were enrolled. And in the CLEAN study, we did have 7 patients that were enrolled. We do have a waiting list for the pridopidine and the RAPA study, but that's why I put my senior research coordinator's picture and contact information there, because we're happy to take your name and information, and if we can get you in, we would love to. I don't have the exact number that were given for pridopidine, but I thought I've heard somewhere around 10 slots. I don't know, Suma, if you know that number.
We're focusing mainly on a rolling basis in terms of admission, so in terms of enrollment. So if a site becomes activated soon and they're allowed to enroll participants, and we really want to make sure that every site that is in the study has an opportunity to be activated and enroll participants. So we don't have set number of slots for each site. It really depends on the activation status. And again, as you mentioned, Dr. Goyal, the wait lists and the the enrollment numbers as they proceed. So, you know, going back to sort of the numbers are always sort of, you know, we always think about how many ALS individuals are there in the country and how many slots are available. There's always a demand and supply mismatch. There's still demand supply mismatch in a big way. But when you look back and think of where we were 5 years ago and where we are right now, it's really amazing to see how the field is really sort of evolving. You know, even 5 years ago, we didn't have any options at all to give participants, patients who are not in clinical trials, Then in around 2018, we started, early efforts for expanded access with single patient EAPs, and that grew into a small cohort of EAPs where the company would give the drug. And then that grew into multi-site EAPs, also on a small scale, as in parallel to the platform trial. And then that then sort of the axeALS then opened doors for many of these programs to be codified on an annual grant cycle sort of format to allow more opportunities. And the difference between the traditional sort of compassionate use of EAPs versus the EAPs that are run through the axeALS is really to see if we can, in addition to the compassionate use access component, if we can run these programs like clinical trials with the same rigor as clinical trials and collect data, whether it's biomarker data or safety data. There's no placebo in EAP, so you can't really do direct efficacy testing, but can always compare it to a historical control or virtual controlled cohort, things like that. So this is all an evolving field, and it's really opening doors in many ways to think about designs and to think about access and how can we bring efficiencies to this process. And I hope that in the years to come, this will only get better and better in terms of the numbers, because
Yeah,
there's a need
totally.
for that.
Yeah, I totally agree with you, Dr. Babu. And I would even add that these EAP programs have happened because of you guys, because of the patient voice. And, the patients really saying, well, we want something while FDA is happening. And so getting these early access programs started has happened because of your voice. And I would thank the patients for even being so involved in all these efforts too.
Thank you, Dr. Goyal. I think we have about 2 minutes left for the webinar, and maybe one final question we can take. And what's the time frame for start of Pridopidine EAP?
At our center, I did check with our team because I knew I'd be in the hot seat for that. But I'm happy to report that we have IRB approval and we actually have our contracts and budgets all ready to go. So it's a matter of just getting some trainings and activation issues. And I'm told from my regulatory team that we're hoping within a few weeks we'll try to get our first patients in. So hopefully very soon.
Exciting. I just want to add to that we have a few sites that are already active and enrolling as well. So this is one of those stages of the life cycle of a study where there's a lot of work that goes on in the background to activate a study and get all the sites activated. But once we start to see sites getting activated, things ramp up very quickly. So you'll see a lot of action in terms of new sites being activated and more opportunities to enroll at different sites over the next few months, few weeks to few months. So exciting. And thank you all so much again for joining our webinar today. And we'll keep the discussion going and stay tuned for the next EAP webinar next month. And a huge thank you to Amanda and Dr. Goyal for joining today's webinar and a fabulous discussion. Thanks, everyone.
And thank you, Amanda, so much for your support at UC Irvine.
Thank you. Thank you, everyone.
Thanks, team. Great to see you.